Good afternoon and welcome to UCSF Family and Community Medicine Grand Rounds. We have a wonderful speaker today and I'm really excited to hear from him. But first we have a few quick announcements, which as always, just a reminder that this session is being recorded and you probably saw that on your screen. If you have questions for the speaker, we'd encourage you to use the Q&A section for this or comments, and we will do our best to address them and to read them out loud, or the speaker will read them and respond to them. If you've missed previous grand rounds and you'd like to see them, the grand rounds from previous sessions are on the UCSF Family Medicine website on YouTube. You can see them there, or if you just want to watch today's grand rounds again, you can do that. It will be posted on in a couple of days, I think by Monday, usually, I believe. Also, we would love your feedback. So if you can take the time, if you have the ability from where you are to fill out an evaluation, there will be one, a link to an evaluation, and we would love your feedback to hear how we can improve this. So our speaker today is Dr. Saul Weiner, and he'll be talking about contextualizing care, an essential and measurable clinical competency. Evidence-based care plans can fail when clinicians do not consider a patient's relevant life circumstances, such as the inability to afford a medication, competing responsibility, or loss of social support when planning for their patient's care. The capacity to systematically identify and incorporate patient life context into medical decision-making can be described as the process of contextualizing care. Based on an analysis of over 500 standardized patient simulations and 7,000 audio recorded clinical encounters over the course of more than a decade, Dr. Weiner's team has characterized the skills required to contextualize care, measured their effect on patient outcomes and healthcare costs, tested various strategies for teaching the skills and measuring performance, and established a contextualizing care QI program at several VA medical centers. Today, his presentation is going to provide an overview of that work. And we're very fortunate to have Dr. Weiner with us today. Dr. Weiner is a professor of medicine, pediatrics, and medical education at the University of Illinois in Chicago, and deputy director of the Research Center for Innovation for Complex Chronic Health Care at the VA. And his latest book is On Becoming a Healer, The Journey from Patient Care to Caring About Your Patients. I'm very excited to hear his presentation today, and I want to welcome Dr. Weiner, and please encourage everyone to use the Q&A section vigorously. Dr. Weiner has told me that he really likes hard questions. So I said we have a very adept group at asking tough questions and comments. So please start sending your thoughts and questions to us right away, and enjoy the presentation. Thanks, Dr. Weiner.
Thank you, Margot. Okay, now the most important question, are my slides visible?
Yes, they are.
They are, perfectly, thank you. So it's a pleasure to talk with all of you about this topic. I've been working in this space for about 18 years, and it's a tough topic to cover in 1 hour, and actually considerably less than 1 hour, and I want to leave plenty of time for questions. So I'm going to try to strike a balance here, but feel free to think about what you'd like to ask me, because there are going to be some gaps here. So the place I'd like to start is sort of fundamentally, what do we mean by we talk about patient life context? And when I was a young attending about over 20 years ago, I noticed that my residents were kind of getting better and better at kind of knowing what the latest research evidence was for managing a variety of clinical states. But often when I would walk into the room and start to chat with the patient, a story would come out. And it would become evident that what looked like a good care plan was no longer going to work for this individual, that we would have to take into account a variety of life issues, such as that they couldn't afford a medication, or that they had lost social support, or that they had a new competing responsibility. And so I started to think of this as almost a competency initially, sort of what do we do to make sure that we as physicians are developing habits that take in information that is a sort of essentially critical to appropriate care planning. So here I sort of define patient life context as patient or caregiver circumstances and behaviors that are relevant to planning care. And I want to start with a case. My team, as Margot mentioned, has been audio recording doctor-patient encounters for many years. We've audio recorded between 7,000 and 8,000 encounters covertly. with physician permission. And we've also done many, many unannounced standardized patient visits. And it's given us this window into what happens when that door is closed. And we spent a great deal of time analyzing these recordings in a very systematic way. This particular case here is just intended to be an illustration, and it actually involves an ER patient. Her name is Mary Garcia, at least for today's talk. She's a 46-year-old Spanish-speaking woman with end-stage renal disease on hemodialysis, secondary to diabetes and hypertension, who presented to the emergency department at Kashlak Memorial Hospital with evidence of generalized edema and mild shortness of breath. She had missed her last hemodialysis session. In the emergency room, her potassium was 6.8 with peak T waves on electrocardiogram, and her blood pressure was 156/77. So this is just supposed to be essentially, I mean, this is a typical presentation of somebody who's missed their dialysis a few times. And by the way, for those of you who listen to the Curbsiders podcast, Kashlak Memorial Hospital is our sort of fake hospital that we use for, that they use and that I've adopted here for naming this institution. So what happens initially is that she receives essentially biomedically based care. She gets calcium gluconate to stable the myocardium. She gets insulin and glucose to drive potassium into cells. She gets some ketoaxylate so that she can stool out the potassium. And of course, definitive care is hemodialysis. She's discharged the next day. And the notes said that the patient was apprised of, quote, the risk of missing hemodialysis sessions and urged of the importance of compliance. So this patient got labeled as a frequent flyer. She came back frequently to the ER, and it was on the fourth ED visit that actually a fourth-year medical student decided to get additional information. This medical student happened to speak Spanish, although of course there's no reason somebody couldn't have gotten an interpreter. And this is what came out during that fourth visit. It turned out that she was the primary caretaker of a 10-year-old grandson with an unrelated renal condition, a glomerular disease. She often had to choose between taking him to a nephrologist north of her home, or at basically to this nephrologist north of her home, which was at Kashlak Memorial Hospital, which was the same ED she was coming to, or going south to her hemodialysis center. And so she was kind of stuck in this catch-22. She relied on a Medicaid van, which would only go from home to healthcare facility, and she prioritized her grandson's care over her own. So you can kind of picture her living south of this medical center, and then her dialysis center is south of her. And then she has to make this difficult decision whenever her grandkid needs care, because she can't go to both places at the same time. And the Medicaid van will only take her to one. So that's why this woman was showing up in the emergency room a lot. And once this came out, the team called the dialysis nurse, and her hemodialysis was moved to Kashlak Memorial Hospital, and she never missed dialysis again, at least in the 8 to 12 months that we followed her. So the question, of course, we would ask ourselves is sort of, what did her doctors, how did this go wrong? Clearly, they had labeled her as a frequent flyer. They weren't thinking about why she might be coming back so often. Why does this happen? There are probably many reasons. Clearly, they weren't asking her why she kept coming back, at least until that fourth visit. They didn't seem curious. They assumed she could just do better if she was told to do better. And the result was that they essentially overlooked relevant life context. That's what we mean by relevant life context. And when that happens, we've coined the term contextual error. So contextual error occurs when a care plan is consistent with research evidence if you're just looking at the biomedical aspects of it, but completely inappropriate if you look at the larger context. And as you can see here, it has consequences. So in our work studying what we call contextual error, we've had to come up with sort of 4 terms. And I want to walk you through them because I'm not into jargon, but these terms are very useful and kind of necessary. And so the first is the idea of a contextual red flag. That's any clue that something in a patient's life situation might be impacting their care. So in this case, it was the frequent missed hemodialysis. The second is any attempt to inquire about a contextual red flag to find out what in a patient's life situation might be impacting their care. And again, in this case, it was asking Ms. Garcia, why? The third is anything in a patient's life situation that is impacting their care. And here it was obviously the backstory, the caregiver responsibility for a grandson. And then finally, it was the concept of a contextualized plan of care, which is a care plan that takes contextual factors into account so that the care plan will be effective. And in this case, it was moving hemodialysis to the same site as where her grandson gets his care. So what I want to suggest to you here is that whenever you're with a patient, and that patient has a contextual red flag, meaning that there's some clue that they're struggling with some life issue that could be complicating in their care. That clue could be emanating either from something that's in the medical record, like that they've been missing appointments, not refilling meds, showing up to the ER a lot, losing control of a chronic condition, or it could be something they say, like, doc, it's been really tough since I've lost my job. Now, when that happens, there are actually 6 pathways that you might take during that next few minutes that's going to determine whether the care plan is ultimately contextualized or whether you end up with a contextual error. Hopefully what you'll do is you'll ask them, you'll probe, you'll say, well, what do you mean it's been tough since you've lost your job? Or can you tell me why you keep coming back to the emergency room? And if you do that, they may reveal they may tell you what's going on. There may be a story that you can do something about. We would call that a contextual factor. Of course, in this case, we learned the story of Ms. Garcia's responsibility for her grandson. Once you find that out, you can then take that information into account and incorporate it into your care plan. And then you end up with what we would call a contextualized care plan. And there's actually one other pathway to that. And that's where you kind of drop the ball. You don't ask them, but they just flat out tell you what's going on. I mean, she could have volunteered that information. She may have been more likely to do that if she was English speaking. And then when you're finally hit over the head with it, you act on that information and you end up with a contextualized care plan. Now, in the interest of time, I'm not going to go through all these pathways, but there are 2 pathways that lead to a contextual error. And then there are 2 pathways that basically lead to just a simple resolution that, oh, this clue turned out to be a nothing burger. This person actually is fine. They don't really need any help. And so my point here is that whenever you're with a patient and there is a clue that they're struggling, whether you do something or not, you're going to go down one of these 6 pathways. Now, I want to kind of take a 30,000-foot view here. I find this chart very helpful. Whenever I'm talking to medical residents, I always say that whenever you're with a patient, you should think about 6 types of information that you should always be considering. The first is the patient's clinical state, which is anything biomedical, like their diagnoses, the state of those conditions, and so forth. The second is the research evidence, which is the knowledge that you bring to bear to manage that clinical state from clinical trials, from textbooks, whatever. Unfortunately, a lot of doctors may kind of just get into the rut where that's all they do. But there's 2 other types of information. There's patient context, which is what we've been talking about today. And then, of course, there's patient preferences when there are choices to be had. I just want to kind of put this into that larger framework. Now, I think that when we're caring for patients, if we are ideally thinking about all of these and we're integrating them, what we're fundamentally doing is we're answering for ourselves the question, what is the best next thing for this patient at this time? And that's what we mean by contextualizing care. It's particular to an individual and it's particular to a moment because life context can change from one visit to the next. We have found it helpful to break down life context into 12 broad domains. And we've arrived at this through focus groups and so forth. And the 6 on the left are just life circumstance areas. So for instance, a patient could be having challenges with their access to care. There could be competing responsibilities. There could be an environmental issue. There could be a financial setback and so forth. And you can start to think about where Ms. Garcia fit into this. And then on the right, we've got things that are sort of happening in the person's head, but they're drivers of behavior, like their attitude towards their illness. Obviously, an emotional state is a very important one. So for instance, the patient has lost control of their diabetes, and it's because they're depressed. We would say their depression is the context for the loss of control of their diabetes. And you're not going to be able to manage their diabetes unless you address the depression. And that's what we mean, again, by context. So we have been studying this for about 18 years using 2 different methods. And by we, I mean myself and my colleague, Alan Schwartz, who is a PhD cognitive psychologist, a really, really good methodologist and statistician. And we initially started doing this with standardized patients, where we basically trained actors to go into practices and basically drop clues that they were struggling with life issues, carry an audio recorder, and essentially allowed us to compare how different physicians react under the same circumstances. And then we moved from there into inviting real patients to carry audio recorders into their visits. And we've done a great deal of both of these, and I'm going to be talking briefly about how we've done this and what we've learned. So this is from an unannounced standardized patient encounter. So imagine this is an actor. Aaron James is a 42-year-old man whose asthma flared up after he lost his insurance and could no longer afford to take an expensive brand name inhaler as prescribed. At one point during the visit with his doctor, he commented that, boy, it's been tough since I lost my job. He was trained to say that. So basically to drop a contextual red flag. In this particular example, from the audio recording, the doctor replied, I'm sorry to hear that. It's been a rough economy lately. And then, do you have any allergies? And you know, we can't see this physician, but what we hear often is the keyboard clicking. We get the sense that they're kind of focused on the computer. They're going through a checklist, and that's kind of driving their questions. So it's kind of a non sequitur. And the outcome here is that this actor, Mr. James, left with a higher prescribed dosage of a medication he already could not afford and a referral for pulmonary function tests. So we would call that a contextual error. Now, the same actor goes on a different visit, and this time when he says, "Boy, it's been tough since I've lost my job," the doctor replies, "I'm sorry to hear that. How's it been tough? Is it affecting your health care?" And Mr. James then reveals that he can't afford his medication. And then when he leaves, he ends up with a much less costly generic version of the same inhaler that he could, presumably afford. And what we see here is a contextualized care plan. What we also see here is a less costly care plan. And this is what we mean by contextualizing care as opposed to avoiding a contextual error. And by sending this actor on 50 visits, we could get a sense of what percentage of physicians would produce a contextual error and what percentage would produce a contextualized care plan under identical circumstances. So it becomes an experimental design. So and only about 30% of the time did this particular actor leave with a care plan that addressed the reason for his asthma symptoms. Most didn't ask the obvious question, how has it been tough since you lost your job, which we would call a contextual probe. Now, we did a number of these cases. All of them were kind of typical of primary care visits. And, the percentages varied, but, it was rare that we crossed 50% in terms of physicians avoiding contextual errors. And this study was all with board certified internal medicine physicians. Of course, we don't know what would have happened had they been family physicians. So I want to take a little bit of a dive into this in terms of what's happening. When the actor says, "Boy, it's been tough since I've lost my job," the provider basically has two opportunities to mess up. They can ignore the probe they can ignore the red flag and not probe. That's, of course, one way to miss the context. And the other is if the actor were to go on and reveal the contextual factor, they can fail even to comment on that. And so we see a lot of both when we listen to audio recordings now, both not just of unannounced standardized patient visits, but of real patient encounters. So after doing a fair amount of USP visits, we realized it was time to take this into real care. And if we were going to be inviting patients to audio record their visits, and we did this both within and outside the VA. I mentioned the VA because the VA has been a very generous funder of a lot of this work. What we discovered is that we would have to have a coding system because, of course, we weren't creating reality here. This was reality. These weren't USP visits. And so we basically had to develop a system of listening to audio recordings for those four elements, for the red flag, for the probe, for the factor, and for the care plan to see whether it was contextualized. And we wanted to get about 85 to 90% inter-rater agreement with different coders. And so we actually ended up developing a program for training coders to get a very high level of reliability so that we would have something that was rigorous, where we had a lot of evidence for construct validity and a high degree of inter-rater reliability. So we called our coding system content coding for contextualization of care. We call it 4C for short. Initially, we coded about 600 real patient visits. Patients carried concealed audio recorders into their visits, and then a research assistant would code it using 4C. And then what we did is we would actually follow these patients for 4 to 6 months and see whether there was a correlation between the care plan being contextualized and the outcome. And we did this using a blinded methodology, and there was, which of course was exciting, but if you think about it, it was also sort of obvious because if what we're coding for is simply when a patient indicates, in this case, a real patient, they're struggling with some sort of life issue, if the physician attempts to figure out what's going on and makes an effort to assist them, not surprisingly, at 4 to 6 months, it is more likely that that patient will have a resolution of that problem than if the physician doesn't. But the point is, it does show that this effort to contextualize care does in fact matter. It matters for patient outcomes. So this is an example from a real patient. Ms. Geller presented with a loss of control of diabetes. Her glycated hemoglobin was 9.7, which of course is too high. It had previously been 7.0, so that would be a contextual red flag. She revealed that she recently moved and her meds got, quote, all messed up. So that's another flag. And the physician did not ask about the medication adherence. The physician increased the dosage of insulin, but did not address the patient's confusion. And at 4 months, the glycated hemoglobin was no better. It was 9.8. So this would be an example of a contextual error. And we hear this on the audio recording. And what our coders do is every single audio recording is distilled into these 4 elements. What was the contextual red flag? What was the probe? What was the contextual factor? And then was it contextualized? And of course, in some of these, it's just that there wasn't any probe. But that's how we are able to distill every encounter into these 4 elements. So we have done many of these studies, and I'm going to just summarize for you here some of the key findings from these studies that I think are worth sharing. First, in about 40% of real ambulatory visits, effective care depends on identifying and addressing patient life context. We found that in about 40% of those encounters in which care depends on attention to context, physicians overlook context, meaning that there is a contextual error. So that's 16% of ambulatory visits that we've studied. We found that contextual errors predict worse healthcare outcomes using the methodology that I've just described, where we use a blinded review at 4 to 6 months to see whether the original contextual red flag has resolved or not. We found that contextual errors result in overuse and misuse of medical services with higher costs, because when you're not identifying and addressing the context, not surprisingly, you're often ordering additional meds and referrals. And in the case of Ms. Garcia, literally, the patient is coming back sick repeatedly. So that would be another example of additional cost because of a failure to contextualize care. We found that there's wide variability across physicians in their attention to life context, which is why we think that this should be regarded as a competency. And one of the most surprising findings is that we found that physicians who contextualize care do not, on average, have longer visits. And we studied this very rigorously using our unannounced standardized patients. And I want to mention this because often when I present this work, at least when I used to present this work, people would say to me, well, this is really nice, but we don't have time for this. Our visits are too short. And what I can now tell people is, yes, our visits are too short, but some of you are actually doing this quite well, while others are not, even when saying literally the same patient. And that's why we were able to make this kind of apples to apples comparison when we used our unannounced standardized patients and compared the timestamp on the audios for visits where the care plan was contextualized compared to when it was not. So, of course, the next question becomes, what can we do about this? We have done studies attempting 3 types of interventions. One is at the level of medical education, one is at the level of quality improvement, and one is at the level of clinical decision support. In medical education, we've done workshops for medical students and residents to try to study whether we can change their performance. What we found in a nutshell, and there have been a series of studies on this, is that we can teach them the skill of contextualizing care so that they do better than a control group in the laboratory of simulation when they're interacting with a standardized patient. But then with those same residents, when we covertly record visits with them, we often find that they fall back to their old bad habits and don't probe. And so I think what we see here is what's called a skills to performance gap, which is it's one thing to teach medical students, physicians to do something, but it's quite another to actually change what they do in practice when no one is watching or when they think no one's watching. So one way to do that is with audit and feedback, which is any method where you kind of keep holding a mirror up to physicians to show them how they're doing. And we designed an audit and feedback intervention for contextualization of care, which I think I'm going to be talking about briefly here in the next slide. Yes, I am, in fact. And then I'm going to talk a little bit about clinical decision support interventions. So the basic idea behind a QI program is patients volunteer to carry an encrypted audio recorder into their visit. The audio recordings are uploaded to a secure server. They basically come out of the visit, they hand it back, and it's force decoded for whether and how the care plan resulted in a contextual error or contextualized care plan. The results are shared with clinicians, both individual examples and overall trends, and each report contains 2 types of data. One is that 4-line summary I showed you, which for every audio recorded encounter, at least select ones that are interesting. What was the contextual red flag? Did the physician probe? What was the factor if it was revealed? And was the care plan ultimately contextualized, or was there contextual error? And then we also graph this data, and I'll show you that in a moment. Basically, over time, we can show a team of physicians. Are you getting better at contextualizing care? Are you getting worse? Are you staying the same? And that becomes a quantitative data point or set of data points. So the biggest study we did, which came out about a year ago, involved about 4,500 physicians, mostly physicians. We had a few PAs, a few nurse practitioners, but essentially recording visits with 666 providers. 67% of audio recordings contained at least one contextual red flag. 55% of the contextual red flags were probed, and 57% of probes uncovered a contextual factor. 67% of care plans were contextualized prior to feedback, and 72% post-feedback. So what we did here is on about every other month basis, we would send basically PowerPoints with examples from that cluster of physicians, from that clinic, to a clinical champion who was typically a peer physician in that group. And they would go over the data at a standing meeting with their peers and say, here's how we're doing. Here are 10 cases that were recorded from our visit in the last 2 months. And these are contextual errors that we're making, and these are the ones we're doing well at. And this idea of just basically continually sharing this data with physicians through a peer over time slowly essentially heightens their awareness of context. And what we saw is that it does lead to more contextualization of care and fewer contextual errors. And so that's what we mean by audit and feedback. And what was even more positive is that we saw that it also led to better outcomes for patients. In other words, the earlier findings were just reproduced, that as we saw more contextualization of care, we saw more resolution of red flags with better outcomes. And we even saw a small reduction in hospitalization rates for the patients of the physicians in this group. It went down just from 19% to 16.5%, but because it was a very large sample size, basically all the patients of 666 providers, it was significant. And when we went, and this was actually a VA study, and when we went into the data warehouse, it prevented almost 1,000 hospitalizations, 987 hospitalizations, with a cost avoidance of $25.2 million. And this intervention, handing out all these audio recorders and collecting them, we actually used a lot of volunteers to do it. So our costs were actually very modest. The major cost was just paying the audio coders. And so it was, as you can see, it was about $337,000. So that was a 75 to 1 return on investment, just if you looked at just the reduced hospitalizations. So I think what we can say is that if you audit and feedback physicians, you keep sharing with them their performance, it does nudge them, and you do see a gradual improvement with benefits for patients. So this is just an example of a graph from one site. I think this was our Los Angeles clinic. We did this in a number of places around the country. And you can see here that, and I have to admit, this one looks good. That's why I'm showing it. We had other clinics where they didn't improve, but on average they improved. Obviously I'm showing off one of our successes. But here you can see 2 lines. The blue line, and these are snapshots in time, are the percent of audio recordings in which a contextual factor was addressed in the care plan, meaning the care was contextualized. And then the yellow line is the percentage of contextual red flags that were probed, where we saw less of a change. But what you can see here, and then each of those points at the bottom represents a feedback session. So a peer physician in that group going over the data with them. And it's kind of zigzaggy, but you see an upward trend here. So, I should also mention, by the way, that we have an agreement with the American Board of Internal Medicine and the American Board of Family Medicine that physicians who participate in this program get maintenance of certification credit. And it's actually, it also counts towards their performance improvement MOC, which is quite nice. So this here is another way of visualizing the data. As I showed you early on at the beginning, we break all of these we divide all of these encounters into these 12 broad domains based on the contextual factors. And you can see for a particular group that access to care was the most common contextual factor, that skills and abilities was a less common contextual factor, and so on and so forth. And what it does is it gives you a picture of kind of what your patients are struggling with in your particular clinic. And we find that this really varies based on the sociodemographics of the clinic population. But it's very useful. It starts to give you sort of almost a population level view of where your patients are facing challenges. The last study I want to share with you is ongoing. It's funded by HRQ. It's a randomized controlled trial. And here we're doing something that many of you may have already thought about, which is we're using clinical decision support tools to try to help physicians contextualize care. What we did is we worked with some programmers in Epic and Cerner, and we basically built a simple tool. The patient fills out a questionnaire in the portal before their visit. And then it's basically ask them questions in these 12 domains. Anything that's positive, any area where they say they're struggling, will basically appear in the physician's template when they open their note, along with their vitals and problem list and so forth. We call it a contextual care box. And then in addition, the system will mine the EHR for 7 common red flags, like frequently missing appointments, not refilling meds, going to the ER a lot, things like that, a sudden increase in A1C or blood pressure. And that'll also go into the contextual care box. And then if there are obvious interventions like getting someone a pill box or contacting a social worker, the system will pre-write orders and just basically pop them up, and the physician just has to accept them. So we're trying to create a system to make it easier for physicians to be informed about context directly by patients and also by mining the EHR. And this is an RCT to see if it makes a difference. And so that's ongoing. I'll just give you a little picture of it here. Essentially, what you see here is at the top is information provided by the patient portal. Here's information provided by the EHR, sort of through just algorithms. And then essentially both of these appear in the physician's note in the contextual care box. There's some alerts and orders, and those are intended to kind of help the physician, address context. And we'll see if it makes a difference. So, I just want to kind of sum this up and sort of say, contextualizing care isn't fancy. If you strip away the jargon, it's really about, figuring out why something's not going the way it is when a patient seems to be struggling, and then seeing if you can do something about it if possible. Now, I just want to share a couple of resources. Alan and I wrote a book a few years ago called Listening for What Matters, which is kind of more for researchers. The subtitle is Avoiding Contextual Errors in Healthcare. And it kind of walks through all of our studies. We're actually now doing a second edition, which I hope will be coming out in about 18 months or so. And then the book on the right is more of a guide for residents, physicians. Really, I think what happened is when I was finishing Listening for What Matters, I realized that this isn't all cognitive, that some of it just has to do with, are we engaging with patients? Are we thinking about them as people who have lives? And how does our medical training unfortunately point us in the wrong direction? What can we do about that? And so this is more kind of like, I would say, almost like a companion that kind of is intended to address what I think, and this again is much more driven by opinion, but certainly my point of view about how I think medical education and residency training sort of turns us into these efficient task completers rather than people who think about our patients as having lives and as that information is being important. And of course, family medicine is all about trying to avert what much of our medical education training has done up to that point. So I think that's, one other thing, podcast. So we're now in our second year. I have a colleague who is a physician in Birmingham. He and I have had a podcast where we try to talk about this. So if you're a podcast person, check us out. We're on any app. It's called On Becoming a Healer. And we also have a website, which is contextualizingcare.org. Not commercial. This is just intended entirely for educational purposes. We hope it's fun and interesting. And if you like them, share them with other people. So I wanted to get through this really quickly by 12:35. And I'm sorry I went so fast, but I wanted to leave lots of time for questions. And if there's more to talk about, I'd love to do that as well. So thank you, everyone. And I'm sorry I had to go so quickly.
You're getting a coffee, by the way.
Oh yeah, no. In call.
Okay, I already see there's some questions.
Can you hear me?
Yep, I can hear you. I already see a couple of questions, but I'm going to defer to you to decide what to ask.
No, I was going to let you, since I really appreciate your thoughtful presentation, and I especially appreciate that you left lots of time for questions and discussions at this point. So I'm going to let you answer the questions from the chat yourself, because I think there's plenty of time to talk about them, and they're very thoughtful questions. Thanks.
Excellent. Let me just pull it up here. So the first question says, also seems like we need to integrate this into medical education, so it's the default approach, part of vital signs. Yeah, and I just want to comment on that. I think this should start at the very beginning of medical school. Particularly if you're doing case-based training. Imagine if, I don't know, take a pharmacology type question, for instance, where you want to know if your medical student knows the right drug for a bug. And so it's a challenging question. It's biomedically focused. And then you kind of throw in a twist at the end. You say, okay, I'm going to tell you what, the patient can't afford that medication. What are you going to do now? And that's basically introducing context. And I think that's what medicine is really like. And I think that if we just got in the habit of doing that at every point where we do case-based learning, at the very beginning of medical school, all the way up. By the time people arrived at their third year, they would already just be in the habit about thinking about context. It would be sort of just part of their, it would be almost knee-jerk. Oh, okay, well, what's the context? And I think that is absolutely necessary, rather than, because we found that these kind of intensive workshops kind of at the M4 year or residency year, they as I said, they inculcate a skill, but they don't change performance. I really think this has to be embedded. The second question here is, thank you for your presentation. I'm struck that your examples display physicians perpetuating structural racism and structural oppression of vulnerable people and people from marginalized communities, and a lack of comprehension of even the most basic elements of social determinants of health. I'm interested in your thoughts on this. Thanks. And I completely agree. There is no question. But what I would say is the problem is actually even bigger than that, because we have found that even if it's a case, let's suppose it's a woman who doesn't fall into any kind of marginalized group, or a man who doesn't fall in any kind of marginalized group. They're well-educated, they're white, they don't have any financial difficulties, but let's suppose that they're I don't know, they have arthritic fingers and they can't dose their insulin because their fingers are arthritic, or their vision is failing from diabetic retinopathy. I'm just giving you examples that have come to mind. And so the patient is not able to give themselves insulin properly, and their A1C goes out of whack. And we still find that physicians will often not figure that out. And so I guess what I'm saying is, I think there's a fundamental inattention to context in real life practice. And of course, any social determinant of health issue is going to be affected by that as well, because that's all context also. And it may be more greatly affected because, as you say, there are these other elements of bias that get introduced, and racism that get layered on top of the tendency to overlook context already. I don't know what the relative risk is of being affected by contextual error if you are from a marginalized group compared to if you're not. In an early study we did, we actually had a white and a black actor for every case. And we actually found that the contextual error rates were so high that it didn't really matter whether they were black or white. Although there were some unexpected findings. We found that our black actors, if they were portraying an uninsured patient, were more likely to be turned away. It wasn't even something we were studying, but they were actors going in. So there were things we saw. So I think that's an important area for further research. Next question here is, we teach this as trauma-informed care. So great to see this full body of work. Thank you. What do we know about physician satisfaction with care and burnout? So this is a really interesting question. Now I'm going to veer into opinion. One of the things that I have found is that the failure to address context, I think, is directly connected to a failure to engage with people who are your patients. It's kind of, you're sitting there, interacting with the computer, you're clicking away, and your patient becomes almost like a data source. That's almost like what it sounds like on a lot of audio recordings, and we've done this all over the place. And that's a lousy way to practice, not just for the patient, but it's also soul sucking. So if you're not engaging with your patient, there's no sense of shared humanity, if you're basically just an efficient task completer, then you're going to burn out. If think you're spending all day, let's suppose you're in an outpatient office and you're seeing, 18, 20 patients, and that's all you're doing, and it's just this checklist approach to care. It's wretched. And so I think that, and I do think to some degree we train physicians to become like that, and then the system, of course, reinforces it. So I think that I've also found that when we've done these audit and feedback interventions, physicians are initially very suspicious about being audio recorded, but once the project is up and running, they often embrace it. They really like the fact that this is not cookie cutter. It's really about thinking about, to what extent are you attending to who your patients are and what they really need. So I actually think, in a certain way, this could be an antidote to burnout. And I think that if it were a performance measure, it would be something that would sort of harness what many people went into medicine for, I think, in the first place. Let's see.
Kevin wanted to ask a question. Since he's a panelist, he's going to ask it live because we can't use the chat from the Q&A from this section. Thanks.
Look, first of all, it's really fabulous, really stimulating. And I just
thank you.
Want to applaud you and your colleagues for, to have this sustained body of work that builds on itself over what sounds like a couple of decades. I think this is just really so impressive how you stuck with this and really trying to get deeper and deeper into this. I mean, I think it has profound implications, and I'm going to pick up Carolyn Fichtenberg's question is along the lines of mine. I mean, I think there's maybe a little bit of tension here on how to approach this best. So, you know, we have the UCSF Siren group, Saul. I don't know if you're familiar.
Yes, I'm very familiar. I've worked with Laura quite a bit.
Yeah, great. So many of them are, you know, attending today's session. And, you know, that approach is we need to build this in a structured screening that's either done, you know, either through a patient portal in advance or by a medical assistant or by the clinician herself, but using kind of a structured approach. And yours, I would say, is much more, let's build it organically into the discourse between a patient and a clinician in the context of a visit, sort of tune into when there may be a red flag that really prompts you to ask about context and work through that. And I mean, this is what I struggle in, you know, I think my care and everybody we're working with, how much is this, like we've lost what good doctoring is about? And I think that's where your book on being a healer, that if we were much better doctors and clinicians attending to the broader context of people's lives, then we'd be getting at this. Or is that even if you were doing a great job at that, would there still be a role for some structured probes? Because, gee, there wasn't a red flag to tell me that, you know, this person has food insecurity, and that helps to have that built in. So I don't want to present these as it's an either or, but I do see a little bit of tension because I think probably one of the risks of the structured approach is to take us off the hook on being better doctors or clinicians to really make this more an organic part of how we're talking to patients and working with them. So,
yeah, you know, I think I'm glad you brought it up. You've identified what I would call both a strength and a weakness of this work. And let me just elaborate. One of the things we found when we did this work is that, you know, in real life, doctors are busy. And we wanted this work to be convincing to physicians in busy practice. And so one of the things we said is that, look, if the basis of this is that there has to be a clue and the physician has to notice and ask about it, we're going to miss stuff, right? As you said, sometimes there's no clue that a patient is struggling. And we acknowledge that, but we also recognize that in real life, we're not going to convince most physicians that they need to take a deep dive into the life of every patient who they have 15 minutes with. And of course, if they have a long-term relationship with a patient, of course, that makes it easier. But sometimes, often they don't. And even if they do, as you said, they may still not know about something that's happened or even happened recently. So we just made a decision that this was going to be based on clues, and that you can't argue with that, right? I mean, if a patient indicates there's a red flag that a patient is struggling, it's hard for even the most skeptical physician to say, well, you know, quite frankly, that's not my problem. It's sort of like saying, well, abdominal pain is not my problem. If the patient says, you know, doc, it's been tough since I've lost my job, and they're on, you know, and they're not taking a medicine that's really expensive, we found that when we share that data with even the most skeptical physicians who didn't pay attention to it, they don't say that's not my job. They're like, oh yeah, that's important. I should have asked about that. I guess I didn't hear that, right? It was negotiating that. But if we were to say to them, you didn't take a comprehensive history, that's a little harder sell. And so we made a decision early on in this work that this was going to be basically grounded on the contextual red flag, the clue, and so that's basically how this works, you know, for better or worse. I hope that addresses your question. I'm not sure. If it doesn't, please let me know.
I mean, so I just said, but so would it be complementary then? Maybe there's a role for some structured screening as well as the approacher. I mean, maybe they actually.
Yeah, no, we're not in any way saying, you know, don't do structured screening of your patients. Of course, that's wonderful if you have the time, you have the resources to do that. It's not something that we measure. Our focus is just on what you've seen, and what we can tell you is that what you've seen matters and that it has predictive power. But absolutely, this is not, I wouldn't want anyone to walk away from this talk saying, you know, I shouldn't be asking patient screening questions. It's just that at a minimum, we're saying this matters.
Thanks.
I just want to call out that there's some really fantastic questions and thoughts shared in the chat right now. And so I wanted to give you a moment to a moment just to look through them and respond to them.
Sure.
Particularly, I think I want to particularly highlight Kirsten's that says, thank you for reinforcing that it's the conversation that gives us joy in our work and that that's actually the real work. To me, I think that sums up a lot.
That's beautiful. Thank you. That's beautiful. Yeah, that's very elegantly said. So there are questions here. I'm just going to go in order. It says, what do you think about efforts to screen for social risk? Oh, I see. That was sort of addressed just now. Can that help with contextualizing care, or do you think it's a problematic approach? And I think I sort of addressed that, which is, I think it's great. It's outside what we measure, but that doesn't mean that it doesn't matter. And as I said, I just sort of articulated that our system is based on picking up on these clues, and that we found that there's already lots and lots of work for physicians to do in terms of picking up on these clues, and that we know that missing them is something that that has adverse effects. The next question here is I think from Laura. Just to clarify, oh, okay, Kevin across Siren's work. I think this might be addressed to Kevin. And let's see, have I missed things? I was not paying enough attention to the chat box.
No, I think you've covered most of the really main points. I wanted to just give you some time to respond and reflect for a few moments with maybe some closing thoughts or summaries before we all head off to our afternoon clinic and other activities. So I really want to thank you for what I think is going to be really the beginning of a thoughtful dialogue for a lot of us here about what's important, why we do the work, how it matters to ourselves and our patients. You've put some great data behind it and asked a lot of great questions for us. And I want to just let anyone else who wants to add their thoughts or questions to the chat right now. And then mostly thank you, Saul, really, and we'll give you the opportunity to wrap up with some closing thoughts. Thanks.
Yeah, I think this, and I actually not sure I've said this before, but I think this work has taken me full circle. And what I mean by that is it started out as an educator when I was noticing, as I mentioned at the beginning of the talk, that this was something that that at least residents and medical students were missing. We later found out that it's something that physicians, attendings miss as well. But and then that kind of led to working with Alan, a partner, to design what turned out to be a very long program of research. And I would say sort of at this stage in my career, I've sort of returned to putting my highest priority on medical education. I feel like right now, what matters to me most is to find ways to bring this into curricula. I feel like, we've tried short fixes, we've tried quick fixes, with workshops, and audit and feedback, as you can see, helps, but heck, it's only helping up to a point. And so I really think this is something that we need to be thinking about. And that's why the paper that I named this talk after, which is referring to this as a competency, is one I'm now eager to share. I asked Roy to post it for you so you can have a look at it, but it's really talking about this as a competency and a kind of grounding it in the work. But I'm really interested in thinking about how we can bring this into every phase of training, of the way we train physicians. So those are my parting thoughts. And again, I so appreciate the opportunity to share this work with you.
Well, thank you for a wonderful presentation. Thank you for everyone who joined us today. As a reminder, if you want to watch this session recorded or other sessions that you've missed, you can look at the website where there's a YouTube version. We also encourage you to fill out your feedback sessions today. And if you have ideas for future speakers, please let me know. And most importantly, thank you. Thank you, Saul, for a great presentation today.
Take care. Thanks so much. Yeah.
Bye-bye. Thanks.